Okay, perfect. Lovely. Well, I guess we can start now. So, hi everyone who's tuning in. Going to be talking today at our first webinar for InferOperate Thorax, a surgeon's perspective. My name is Swati, and I'm going to be your host for this exciting session. We're here today to explore our new technology, InferOperate Thorax, in transforming thoracic surgery. So, in essence, this tool offers a quick 3D reconstruction of the thorax with the aim to allow surgeons to enhance their pre-surgical planning, identify any anatomical variants, and make decisions that can preserve more lung tissue and ultimately help improve patient outcomes as well. So we're delighted to have our two esteemed speakers joining us today. We've got Dr. Etienne and Dr. Cassihan. Dr. Etienne is a thoracic surgeon from Hôpital Tinon in Paris, and Dr. Cassihan is a thoracic surgeon from the University Hospital Frankfurt in Germany. So over the next kind of 30 minutes, they'll be sharing their real world experiences with InferOperate Thorax. And they'll be sharing their cases and how this technology has played a pivotal role in their decision making. We'll be kind of going into some discussion about the key questions, and very happy for kind of audience participation. So please send in your questions. And essentially, it should be a learning opportunity for all of us here today. So without further ado, I'll welcome our first speaker, Dr. Etienne. Thank you for joining us today. And I want you to start off by just sharing your first impressions of InferOperate Thorax. And then if you can present your cases as well, that would be lovely. Thank you.
Well, thank you for this nice presentation, Farah, and thank you also for this invitation. So it is my pleasure to talk about InferVision that I've been using for a little more over than a year now for all my segmentectomy reconstruction before surgery. So for me, it has been, I would say, a game changer for a lot of cases because it allows me to better anticipate anatomical variation, and the fact that it's easy to use software with which doesn't necessarily need uh, um, an injected CT scan also facilitate a lot of things. So you don't have to recall the patient to do an injected CT scan. So that's a big change. So I would like to present one case, a case that I did a couple months ago. It was a very interesting case. So to start, so it was a 74-year-old male who had a nodule on the right upper lobe. So you can see here on the CT scan, it was a apical nodule, which was known since 2019, but he had been slowly growing. He had a past medical history of nephrectomy for urothelial cancer. That was in 2020. He was quite a big smoker with 70 pack years. So on the last CT scan he had for the follow-up for his cancer, so we saw that the nodule kind of grow. It was about 12 millimeters, and we did a PET CT, which found that the standardized optic value was about 4, which is, I would say, it's starting to get quite high for such a lesion. The brain CT was normal. There was no other lesion visible. So, of course, tumor board would favor for that patient to resection. So we did the functional respiratory test. It was 77% for FEV1 and TLCO was 79%. So since it was a less than 2 centimeter lesion that was quite peripheral, so we would go for a segmentectomy rather than lobectomy. And in our institution, we never do wedges for those kind of lesions. So every time we think it's cancer, we always go direct for segmentectomies. So that's the initial CT scan. Then I did the reconstruction, which I'm gonna share with you guys. And it's gonna allow me to explain to you how I use that the software. So basically, this is the how the software looks. This is the CT scan, the initial one. So usually you see that the AI focuses on the lesion, you're gonna use that lesion to do the reconstruction. So here I'm gonna make the slides go down. So there was no other lesion visible on the CT scan. Then this is the reconstruction, which is, so usually I start by going to lobes mode because that allow me to focus only on the right lung. So I can take out the left upper lobe, the left lower lobe, and then we can start focusing on the right lung. So what is usually easier is to cut out the arteries on the other lobes that don't interest you on the same side, which means that we're on the right side. So I'm gonna take out the arteries for the middle lobe, then the lower lobe also. And then also the bronchi for the lower lobe. And at last, the bronchi for the middle lobe. So you see, it's quite fast to do though. So once I do that, then I'm gonna focus on the different structures for the upper lobe to start seeing if there's anything that seems out of the usual or rather unusual. So for the upper lobe, then I'm gonna cut out the vessels. So I'm gonna take out the artery and the vein, and then I'm gonna focus on the bronchi first. And right away, something strikes us on the bronchi because you see here is the lesion. So that's 1.2 centimeter lesion. Then you have this, you have the main bronchus who's supposed to be here, which is very, very short. It's like less than a centimeter. Then immediately you have a bronchus that comes out of it. And you would guess that this is the upper lobe bronchus, but when you go a little further down, you have a second bronchus that goes also for the upper lobe. So what we find here is that we have a B1 bronchus, which is apical, that goes straight to the segment where the lesion is. And then we have the B2 and B3 bronchus, which comes out after. And then we have the intermediate bronchus. So this is this is a very rare situation. I think that was the first time I came up on this kind of situation. And I can tell you, when you're doing a video thoracoscopy and you stumble upon such anomaly when you started doing the lymph node dissection on station 7, then go for the intermediate and upper lobe bronchus, then it's quite a good thing to know that before, but otherwise you're going to be quite surprised and you're going to feel a little bit confused on what's going on during that surgery. So we can verify this so by start delimiting the segment 1, which we see here. And if I'm going to delimit segment 2 here and segment 3, so we can confirm that there's one bronchus that that is separate for segment 1, and there are the other bronchus that goes for segment 2 and segment 3 both. Okay, so that was the first thing. So once you start seeing those kind of variations, so you always have to be careful if there's anything else on the artery and the vein. So then I focus on the artery, and from what I can see when you start looking at the artery is that there's a truncus here. Up, comes out here. And basically, we have to be careful because there's a branch that goes for, there's a branch that goes for segment 1, which is right up there. And then when you go a little further, you're gonna have a branch for segment 2, which is there. So it kind of seemed quite normal from what we usually are used to. And then afterwards, you can focus on the vein. And then here you see the vein. The vein, you have also this typical vein that goes through the suture for the dorsal segment. So that's quite normal. And then for the vein, you have to be very careful to just cut this first branch and not the second one here that comes out of the upper stump. You have to cut just this one in order to preserve segment 2 and segment 3. So when we go back to, so I don't have time to present to you the whole surgery, but I have an interesting slide to share with you about this surgery. Something's it's not working right. So yeah, so this was a case presentation. And when we go to this last slide, so you're gonna see here what I saw preoperatively. So so what was chosen was to do this case by VATS. So here I had done the station 7 lymph node dissection, and then I started dissecting the bronchus from behind. So this is from behind, and as you can see, main bronchus is here, so it's quite short. And then we see this first bronchus that goes out, which is B1, correspond to this one. And then after we have a second one that goes out. So here the mistake would be to think that, oh, here we have the upper bronchus, then the intermediate bronchus, and which is why, once again, it's important to have this reconstruction. So this bronchus is B2 and B3, and then we have the intermediate bronchus. And then we see that typical station 11 lymph node between the intermediate bronchus and the upper lobe bronchus. So at the end, yeah, so the patient ended up having a segment 1 segmenectomy. So everything went well. You had the post-operative follow-up that was quite simple. You had a 3-day stay at hospital, and pathology came back for pulmonary adenocarcinoma invasive. So he had no additional therapy after that. So this is the case I wanted to present it to you. I know that Mrs. Vara, you have some question for me to answer?
Yeah, sure. That was excellent. Sounds like it was a really unique case in terms of how you tackled it and kind of the level of detail that you required. I guess kind of first question is kind of how easy or challenging was it to actually integrate the software into your workflow? Were there any particular aspects of that you found easy or challenging?
I think it was quite easy because, as you saw since I showed live every step from bronchus analysis to arterial and vein, so it's quite easy to pick up as a software. And one thing that I appreciate is that once you upload your DICOM images, the reconstruction is done automatically, and it takes usually about 5 to 10 minutes. So basically, there's no real work for us to do except to upload the image, then analyze it. And I think once you got how you say that you have you put in place a couple steps, like you say, okay, I'm gonna focus on the lung that has the lesion, and you start cutting out step by step all the structures that are not necessary. It allows you to better analyze every anatomic specificities of the segment you aim at resecting.
Brilliant. And how accurate have you found the kind of minutiae anatomy that you see on the 3D reconstruction?
Well, usually for big vessels and all that comes around for the segment, I think it's pretty accurate. Then again, what we have to always be aware of is that the CT scan is done from inflated lungs. And then once we're operating, the lungs are now no longer inflated. So there might be some changes in the anatomy. There might be some small vessel that's 1 or 2 millimeter big that you might not detect with the reconstruction. But I think the main specificity, the main variations are so far well described by this software. And I know, I mean, one of the most frequent variation I come up on the left side is the L4, L5 segment artery that comes before the bronchus, or prebronchial L4, L5 artery. And I know it's always nice to know that before the surgery, because it kind of, you're more careful when you're gonna cut the vein first. So every time I found it on the reconstruction, it was accurate during the procedure. So I have nothing much to criticize about that.
Brilliant, brilliant. We do have one question just popping up on the chat. So
Yeah.
from Jing Wang. So they're asking whether this patient did have a preoperative bronchoscopy or not.
He did, and sometimes, I mean, and when I saw it, they didn't necessarily describe it, because we don't do the bronchoscopy. Usually, it's the pulmonologist who does it, and what we focus on usually is to know if it's normal, or if there's any lesion or not. So to tell the truth, usually we just read the conclusion, and I took a look back on the report, and it wasn't described that they had this particularly anomaly. So, but it's a pretty good question. I think if I had done, or if the surgeon had done the bronchoscopy, which never happens in our hospital, of course we would have come up on this rare variation.
Brilliant, brilliant. Thank you. So I think we'll have more time at the end for kind of questions for both of you and Dr. Cassahan. I think for now we'll move on to Dr. Cassahan's cases and for
Okay.
him to present.
Okay, so I'm gonna start sharing my screen now. Okay,
Sure.
good.
Okay, my name is Dr. Casso and I work in Germany, as Fatih already said, at the University Hospital in Frankfurt. Thank you for giving me the opportunity to speak here. We have been using the program by InferVision since about a year, and we have had similar experiences as Dr. Etienne. We use it standardly for segmentectomies, and we do it preoperatively. What we also do is take the 3D reconstruction and project it onto the screens intraoperatively, just as a security to match the structures. And yeah, until now we had good experiences, and we're in the process of evaluating the data for the patients we use this on. So I brought two cases. First case is a 69-year-old patient who came to our clinic with a suspicious lesion in the right side of the lung from the CT scan in segment 1. We ran the 3D reconstruction on the patient, and it's not a very we also use the low mode as the colleagues in Paris, and we found a pretty common anomaly, namely that there are two arteries to the segment 1, not as uncommon as the case that Dr. Etienne showed us, but also which can be challenging intraoperatively when you have to preparate the structures and see which structures are matching to which segment. So it can be time saving, or when you know it beforehand, and also it can be it can also reduce the incidence of risks, or it can reduce the risk of lesion to the blood vessels. So after it, the patient was presented on our 2-room board after staging, which was where there was nothing special. And we decided to do a VAT segmentectomy. This is the setup as already described in the beginning. On the one side, we can see the thoracoscopy, And on the side behind, we have the screen, or we have the platform open, the cloud, where we can at any time see or match the structures, or if we find anything suspicious in the situs or something we don't understand, we can look back at the structure. So here again, I matched it with the InferOperate finding. So you can see the segment 1 arteries here on this side, and the vein, just as in the structure. And behind it, if you would have turned it around now, you can see that there's one bronchus. So it was a pretty quick surgery. We could identify the structures. We knew from the reconstruction that this is the structures. Of course, we also preparate so we can see the other structures to match if it is according to the 3D reconstruction. And we found it to be in this case. And then we dissected the artery and the bronchus. And yeah, this is the pictures of the segment. And after the resection of the segment, operation time was pretty short, I think 124 minutes, and blood loss was minimal, 50 milliliters, no complication, and the patient could be discharged at the 4th day after operation. It was an early stage pulmonary SCC, and the patient needed no further therapy afterwards. This is the first case. I wanted to showcase how it can help, or how the program in our hours can help with the preoperative planning in respect of anomalies. Another case where the 3D reconstruction can be helpful is determining the surgical margins. I brought a case from a 70-year-old patient. He came to our clinic with an GGN in the segment 10, pretty dorsal, 1.8 centimeters. We did the 3D reconstruction. And the 3D reconstruction, what we found is that the lesion is in the segment 10, but it is at the segment border to segment 9. So in preoperative planning, we incorporated this and planned within segment 10 resection plus a wedge resection of the segment 9. There are other cases. Unfortunately, I didn't have enough time to look them up, where the preoperative planning changed after 3D reconstruction in comparison to just citing the CT. We had 2 or 3 cases, I need to look them up, where the tumor was in a different segment than would have been thought only seeing the CT. In one case, the tumor was pretty ventral in the upper lobe, and just from the CT, we thought it was a segment 3. It wasn't a segment 3, but after the reconstruction, we could see that the patient had like an overlapping segment 1, and we incorporated it and did a segment 1 resection. That also saved us time beforehand. Yes. Yeah, and yeah, we decided then for subscaphoidal segment 10, wedge resection segment 9. These are just the intraoperative fixtures. There were like no further anomalies. It's the bronchus. Here's the artery. And yes, and it was a lipidic adenocarcinoma. Operation hour was a bit longer because it's more difficult, of course, to operate in the lower lobe. Discharge time or discharge was the first postoperative day, and blood loss was also pretty low, I think. Yeah, and as a conclusion, I think we can say that the reconstruction preoperatively, it helps with the identification of variants, makes planning more efficient, and also it helps with the correct assignment of the nodes to the segment, which also makes the whole procedure more efficient and safer.
Brilliant, that's great. It's great to hear that you had the opportunity to kind of change your planning after seeing the 3D reconstruction as well. That's really interesting. I guess kind of one question from my side is in terms of you looking at patient outcomes. I know you mentioned a few there. Broadly speaking, have you noticed that there has been kind of better patient outcomes after utilizing the 3D reconstruction tool, or is it much the same?
I mean, we're still collecting the data and we haven't evaluated it yet, so I cannot give like a scientific answer. But just from my personal feeling, if you take the time and do the proper planning with the program, the operation is just it's more straightforward. You can go for the structures, you know where the structures are, and that saves time and is also safer for the patient. That's my experience, but we don't have the data yet to
Of course. Hopefully soon, and I'm sure that will be very interesting to see kind of what that shows. I guess I'm going to open up the floor then just for a few other questions that have come through. I guess someone's asking kind of, were there any initial challenges with staff training or kind of acceptance of using this new technology in your practice? How has that been for both of you?
Well, I would say that usually for all the surgeons, usually over 50 or 60-year-olds that been having their own technique, been using, they usually they don't want to pick up on those kind of new technologies so fast, unlike younger surgeons and young residents who are more keen into technologies. So that was the main challenge, I would say, in my department. But since we have a head of department which is quite dynamic and always listen to what we have to say, so when the younger surgeons told them and the resident told them that 3D reconstruction would maybe facilitate operation, that's when he gave us a green light to start using it, I would say.
From my experience, we didn't have really any trouble because it's not really it doesn't require a lot of work. So you just need the CT scan that you look at anyways, and then you can extract it and upload it to the cloud, and that's it. It takes maybe all in all, it takes maybe 20 minutes, half an hour to the max, or let's say 20 minutes, and the time you gain at the end it makes the whole procedure, the preoperative planning, it makes it shorter, and you're not dependent on any other specialties or any other people in the OR. It is something that we can do on our own, and we haven't had any problems establishing it.
Brilliant.
And I would add just one is that once you start doing them for segmentectomies and you start detecting anatomical variation, like Dr. Casaun showed, or what I found, you don't want to do any more segmentectomy without it. I don't know what your experience on that, Dr. Casaun, but for me, I mean, every time I don't have it, I feel uncomfortable.
Yes, definitely. It's a very helpful device, and it shows. Yeah.
That's great. We did have one question in the chat. So they're asking whether you're required to do any recalibration prior to using the software.
Well, that's the advantage because there are multiple software out there, of course, which are different. There are the semi-automatic one. There are the ones you have to kind of trying to distinguish the arteries, the vein, the one which needs an injected CT scan. So I tested a bunch of different ones, and of course, one of the main advantage of the InferVision is that you, like Dr. Casaun said, we don't have to do anything. You just upload the DICOM images and it runs it. The algorithm runs it for 5-10 minutes. Then it gives you the final result. So which comes out, and so far I didn't have to modify anything. I just had to explore the reconstruction and plan my surgery accordingly.
Perfect. And another question just about kind of uploading onto the cloud. So what about the patient identifiable data? So I guess I can answer that from InferVision's point of view, but it is all pseudo-anonymized as you upload onto the cloud. So that seems to, we're trying to protect patient data as much as possible there. I know we're coming towards the end of our time. I guess I'm just going to end with kind of one question to you each. So I guess kind of what piece of advice would you share to a budding surgeon who's considering adopting this tool? Kind of what would it be?
Could you just repeat what are we on? Yeah.
Sure. Just if you had one piece of advice to share to a surgeon who might be willing to try out this technology, what would that advice be?
Okay. Well, for me, I would definitely encourage them to do it, especially if they're doing segmentectomies in minimal invasive surgery, because we all know that minimal invasive surgery, we have a narrowed vision, narrower as when we do open thoracotomy or conventional thoracotomy. So it's always better to have how would you say, like some kind of Google map of the thorax, which allows you to identify everything from the artery, the veins, and the bronchus, and to make you more comfortable in whatever you're doing. So I would definitely encourage everybody who's not using them to maybe give it a try, and maybe they'll be convinced by just trying once or twice and do it for every segmentectomies afterwards.
My advice would be the program definitely has benefits, but when you acquire the program or when you try to use it, when you try to incorporate it, you should definitely at the beginning or even further in the cases always take your time, maybe try to incorporate it into your into the morning briefing, to take your time and look at the 3D reconstruction. Because when you're trying to do it in the OR, it can be fairly confusing, because the 3D reconstruction is great help, but you need some time, you need some calmity to distinguish all the structures, and that would be my advice. It takes maybe 5 minutes or 10 minutes per case, and it can save you a lot of time during the operation, but it has to be done.
Brilliant, brilliant. Yeah, I guess you would be taking that time anyhow if you're looking through a CT scan. So you're just kind of extrapolating that onto the 3D reconstruction tool now. Well, I guess time is up now for our webinar. Thank you both very much for presenting your cases and kind of giving your insights on this technology. It's been very interesting to hear about your unique experiences. And if anyone is interested who's watching, please reach out to kind of the InferVision team. We can set up a demo for you as well. Thank you again to Dr. Etienne and Dr. Cassian. It's been a pleasure.
Thank you for inviting us.
Thank you very much.
Thank you.
Brilliant, brilliant, lovely. Okay then.
Have a good evening.
Bye now.
Bye-bye.